Welcome to Acute Conversations, the official podcast of APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect to your profession. I'm Ashley.
And I'm Leo. Today we chat with Brian.Hull and Emelia McCuen, who are part of a research team who published a pilot study titled The Process of Implementing a Mobility Technician in the General Medicine and Surgical Population to Increase Patient Mobility and Improve Hospital Quality Measures, a pilot study. We discussed the use of mobility techs in the hospital, the barriers involved,
and how this is all related to Falls and PT Month. Let's welcome our guest.
All right, welcome to Acute Conversations. We've got two clinicians here that we're going to be talking about for the month of October. It is Falls Month through APTA, and APTA has tasked APTA Acute Care to maybe discuss a little bit about falls and falls implications. And so today we've got two guests. Let me introduce them. We have Dr. Emelia McCuen, who is coming from Bowling Green State University's DPT program. She's an assistant clinical professor and assistant director of admissions. We also have a returning guest, Dr. Brian.Hull, who is the director of rehabilitation for Baylor University Medical Center in Dallas. And actually, Emelia, it was at Baylor that you were working with Brian. Is that correct?
Absolutely.
Awesome.
We enjoyed that time together. We have worked together on plenty of projects at Baylor.
Yeah. And so the reason that we had invited them onto the podcast is because they wrote an article that was featured in Jackpot. And the title is The Process of Implementing a Mobility Technician in the General Medicine and Surgical Population to Increase Patient Mobility and Improve Hospital Quality Measures. It was a pilot study. And part of the results that I looked at was its effect on falls in patient mobility. So Dr. McCuen and Brian, can you talk a little bit about this article, kind of like its origin story?
Sure. This pilot study started out of our awareness of receiving lots and lots of physical therapy evaluation and treat orders for patients that did not have skilled therapy needs. And when we took the time to really dig into the why, it was because other entities within the hospital system didn't feel comfortable with mobilizing patients who didn't have mobility deficit. They weren't comfortable with the assessment of the patient. They weren't comfortable identifying what the concerns were. And we noticed that the fall risk was increasing. The sequelae related to bed rest was increasing. Our patients were having increased discharge recommendations to post-acute care facilities that weren't necessary because at baseline, they walked into the hospital. And based on what they were there for, the expectation that they should have been able to walk out and return to their prior level of function, which for most of them was a home or some type of community independent living facility. And so when we tried to address that from an internal perspective of how can we help the therapy department be more effective and really make sure we were managing our resources appropriately to see the patients we needed to see, and then also make sure that we were implementing effective therapy, we had to kind of step back and say, why are we getting so many referrals that we would consider inappropriate? And that's really where, this pilot started from, was just really looking at the data and what patients we were seeing and why, and talking to different therapists and the nursing staff and the physicians and really trying to get to the root of the concern. And once we realized all the variables at play, which stated that we just really needed to get patients up and moving, Brian and I sat down and we had a conversation about what can we do? How can we help solve some problems with the maximum effect and the minimum harm to the hospital system and structures and processes?
Yeah. Go ahead, Brian.
Let's say, right around this time, 2017 time frame, the hospital's also looking at readmissions and trying to fix those as well. And what was nice about it, this project here is definitely a, building on the shoulders of giants type of project, because around the same time when we were trying to figure out, all right, so what are some solutions? How can we help the hospital with getting more patients able to get home? Help out with decreasing falls, decreasing readmissions, all of these different things. And Jason Falvey just put out a couple of papers in, I think, 2015 and 16 on hospital-acquired deconditioning, and physical therapist roles in readmission. And then there's the also around the same time, I think it's Groudon, physician, and I think and Jamie put out something on the tension between mobilities and fall prevention. So all of these really great papers kind of framing up the situation. So Mila and I would read through these like, yes, these people get it. How can we translate all of this to our hospital? And it came together in this pilot that really helped us define how, if you just go back to the basics of mobility, human beings weren't designed to be flat on their back. So why is it that when they're in the hospital, they're lying flat on their back for 23.5 hours a day?
Mm-hmm. Mm-hmm.
When you're at home, even if you're sick, at the very least, you get up to the couch to watch Netflix for 10 hours, right? You're upright and maybe go to the bathroom a couple times and then you go back to bed. But you never just lay flat on your back for 23 hours. So how can we change these things around? And as I mentioned, all these great minds out there had just published some really wonderful papers like, yes, 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 yes. Let's put all that together and give it a try.
It's so funny you mentioned how often they're in the bed when they're in the hospital. It's so true because I remember, I can't remember where I was at the time, but it was something about how like mobility is medicine. It had some sort of theme, right? And I remember them talking about like, who ever thought to design these hospital rooms where they put the bed right smack dab in the middle of the room and the bed becomes like the center focus of everything. And it's like everything revolves around the bed. You can't even like hardly move because the bed takes up half the room. And so it's so true. I feel like we need to redesign hospital rooms too. So like the bed's over kind of like in the far corner, and then there's all this room to mobilize. Brand that wouldn't make the nurse's job any easier. But I remember all these papers that you're talking about and that you just mentioned, and specifically the one about the tension between mobility and falls. And this concept of a mobility tech has been around for a while, and I don't know how well we're doing it yet. So I'm just really curious to hear from your perspective and your experience trying to implement this because, we've had similar challenges in our hospital system too, where, you know, there's tension about like, you don't want to get the patients up and get them moving because they might fall, right? Because there's so much emphasis on how many days has it been since our last fall, right? So no one wants a fall to happen. But yet, if we don't get these people up, they're more likely to fall because now they're just going to get weak and more deconditioned and more off balance. But we need to get them up to prevent falls. And that concept is really difficult for people to wrap their brains around. So I'm curious in your experience of doing this mobility tech pilot project, how much education did you have to do? How many barriers did you come across? Like, and what was the challenges you had to overcome to make this happen?
Education happened on every level. We started with the higher ups to even let them understand why we were doing this type of project. We had to, of course, you have to get approval if you're going to do some type of project, pilot, or otherwise within the hospital system. So it started with educating executive leadership and then moving down to unit leadership because we needed the support and the buy-in of our nursing colleagues to help this program be successful. And especially because we were asking to implement it on their unit in their homes. And so, and we wanted it to be collaborative. It wasn't physical therapy trying to tell everybody they were doing it wrong and they didn't know what they were doing. It was a way for us to say, hey, we all work here together. We have a unique concern. We want to prevent falls. This is an idea. Can we try it together? And so we did preliminary education to the nursing colleagues. We did follow-up education to the nursing colleagues. And one of the things we identified in the paper as a limitation is that with the nursing colleagues switching off every 2 to 3 days of a shift, it's almost like we had to do daily education to remind them, hey, this pilot is going on, and this is the mobility tech, and this is what we need you to do with your morning assessment. And these are the things we need you to identify and put these patients on the list so that when the mobility tech shows up, they have a list of patients that they can actually work with. And it took a couple of weeks of really saying, hey, here's the form. There are only 3 patients on it. We've got a full house. I'm sure some other people count. Can we get them on the list? And once we did that education, it was helpful, but we also had to do that education to the therapy staff, right? Because we were trying to help them understand, also help us identify the patients that you think would benefit from an extra mobility session. It's not saying that they don't need skilled therapy. You're doing the skilled part. But what about the patients that are on your list that maybe you have put on monitor or that you've screened out? Would they also be appropriate for mobility? Have that conversation with the nursing staff. Let's get these people on the list. So we were educated across the board, including physicians. Hey, we see you wrote an order for this patient. We've screened them out. It seems like they'd be appropriate for a mobility tech. Is there anything that we're missing, right? Because we always want to make sure that we're including other people's lenses. And once we were able to do that, we were truly able to identify those patients whose mobility was not far off from their baseline, which is another concept that people miss. Everybody's not independent walking around without an assistive device. There are some people that, due to the nature of whatever medical comorbidities they have a need for assistance with mobility. So if you just help them do what they do at their baseline, you can help them maintain that strength, maintain that balance, maintain their prior level of function, which carries over to a decrease in falls by the nature of not letting them get deconditioned, which Brian just spoke about with the hospital-associated deconditioning. There are plenty of people who come in and they're ambulatory. They're fine. We add deconditioning to them and increase their risk of falls or put them in a situation where we're not providing adequate assistance when they need it, which then increases their risk of falls. So that's really how that really went with the education pieces. We had to educate often, early, and continuously to ensure that everybody really understood the goal of the mobility tech pilot.
Right, because you have to get buy-in because PT can't be like a one-man or one-woman show, right?
No, and I'm going to tell you, the nurses loved it. We didn't have
Wow.
difficulty. I want to speak to that. Nursing colleagues and our physician colleagues loved it. They
That's
were on
great.
board. And some of it was, it decreased the burden on the nursing staff. And I really want to speak to the patient care technicians, because a lot of times we say nursing colleagues and we talk about the RNs. And yes, they do participate in all aspects of the patient's care, but a lot of that in the weeds mobility happens with our patient care technicians, our certified nursing assistants. And they're the ones getting the patients up to the bathroom. They're the ones getting them up to the chair for meals. And they're the ones who are tasked with taking them for walks in the hallway. Well, if you look at our paper, sometimes that ratio was 9 patients to 1 patient care technician.
Wow.
How much can you ask them to do outside of that and also make sure these patients are up, walking, or mobilizing at their level 2 to 3 more times a day? The mathematics of it is that it's not possible. They
Right.
really did need some help. And so having that mobility technician on the floor to help get some of those patients that were low-hanging fruit off of their plate made their jobs easier. So it was really well supported.
I'd
No,
say
doing-
one key piece that really helped out with this whole thing is Johns Hopkins highest level mobility, HLM. That had come out around the same time. And so, we're so used as therapists to talking in our world. And, so sometimes the easiest things we think we can translate are, the AMPAC scores and this and that. I'm like, what are you talking about, AMPAC? That makes no sense to me when you're talking to people outside our profession. But I have the article right here, the HLM score. We printed that up for everyone, and it was extremely easy to educate all of our colleagues outside our rehab profession to do it. And it's essentially, as Emelia mentioned, when we're talking with everyone, it's like, all right, where are they on this? And okay, call that a 4. The goal today is to get 5, to get 1 more. What's the goal tomorrow? To get 1 more. What's the goal tomorrow? To get 1 more. Talk about a really simple structure. So definitely a big shout out to the Hopkins group. And they had put out, I can't remember if they put out the data when they released the HLM or not, but they talked about how in general medicine unit, they decreased length of stay with really progressive activity mobility promotion by 0.4 day decrease in length of stay with 0 increase for falls. So, as we're talking with the executives, like, but what about falls? But what about this?
Mhm.
Well, okay, Johns Hopkins has 0 falls and they're decreasing length of stay. So, and they helped us out by putting this really easy to follow scale out there. So let's give it a shot. And, as Emelia mentioned, people were extremely receptive, and it was really fun to see different professions pull together and want to learn and tell me more about this. And I give Emelia full credit. She was the person on the two units, the medicine and the surgical unit, bouncing between both of them, on the fly education. What about this? What about this? What are your questions? I can talk to you. I'll talk to the nurse. I'll talk to the PCT. She was just educating between, was it the 9th and the 16th floor, right?
Yes.
So you got a lot of stair work in.
Yes. It did help that I was stationed in that building, but
You got
I
your
didn't
steps.
get all of my steps in during that pilot.
You know what's great is just engaging in this conversation. I'm thinking about our listeners that are out there that are hearing this and saying like, yes, this is exactly situations that I see when I go into the hospital, when I go into the clinic. And one of the things I hear too is this interprofessional play that we have back and forth. It can be a positive, it can be a negative. Part of the fun thing about acute care is that interprofessional interactions where we're interacting with nurses and case managers and techs and CNAs and physicians, right? But at the same time, like there's positive effects of that. There's also the negatives about having that communication and whose responsibility is. You can't put this on my plate. We already have enough to do. And so, what I think is great is that you had there was a problem that you detected, and you said, okay, here's some possible solutions. And again, just thinking about our listeners, thank you, Brian, for mentioning this. When you look at at your article, you referenced that Johns Hopkins mobility scale. And what's nice is that as I do different site visits, as I visit my students, I'm seeing it more and more on different walls. I'm like, oh, cool. So this is being implemented. But for those listeners that are out there, please look at the article. And if that's one thing that one piece of information, part of evidence that you can start implementing in your practice, like right after you hear this, is using this mobility scale and talking to your supervisors and your colleagues and see, can we implement this and start off with the education? And so, Emelia, you had talked about this conversation with nursing staff, right?
Mhm.
And some of the different research. What's interesting is that I came across an article which I think stems all the way from 2013. It was featured in the PT Journal. It's called "Move to Improve the Feasibility of Using an Early Mobility Protocol to Increase Ambulations in the Intensive and Immediate Care Settings." But that article was not written by PTs. That article was written by nursing staff, which was featured in our PT Journal. So again, it just talks again about this interprofessional, interdisciplinary interaction that we have, and all hands have to be on deck if we want good outcomes for our patients. So can you talk, you said the nurses had pretty good buy-in. How else, as you were rolling this out, what are some of the other effects that you saw?
So I'm glad you asked that because I sure had a piggyback as soon as you brought that up. We talked about one of the limitations being that we really didn't get to see the mobility tech continue after the end of the pilot. There were some other constraints that kept that from happening, but there were some benefits from the pilot that still carry into the hospital now. One of the things is the units enjoyed the highest level of mobility scale so much that they printed different ways to identify the level of mobility for their patients, and they start sitting them outside the door. For example, when you look at the printed copy in color of the Johns Hopkins highest level of mobility, each level has a different color. They started using that color system with the number system and putting them on magnets outside of the door, and they would do something simple like just mark this patient's a 4, this patient's a 3, so that if the call light went off and somebody walked in, they already knew what level of mobility this patient is in. And so if they're calling to go to the bathroom, if this person is at a 7 or 8 and they can get up and go to the bathroom.
That's
So
correct.
that was one big carryover. I also think that there was a push to figure out how we could better get our patients moving. One of the things Brian and I did prior to this paper, which was our data gathering phase, was we looked at the amount of movement our patients were doing because it was documented that our patients were walking every single day. And they were. But when we looked at how many were walking at less than 25 feet per day, you could tell there was a big difference. So yeah, they're walking to the bathroom. Yes, they're walking in their room. But our goal was to get them out into the hallway and getting closer to that 200 feet, 250 feet, 500 feet. And so after this pilot and the comfort that the nurses saw with these patients getting up and moving, our tech sometimes had a gait belt on the patient and was just walking next to them. Didn't have a hand on them or anything. And when they saw that, oh, these patients really can move, it helped them keep that going. I think a lot of these units they kept their mobility going with nursing staffs and with the PCTs because they saw that some of the barriers that they were concerned about with being able to get the patients out of the bed, getting them to the chair, the safety of them walking in the hallway, and really the time it took to participate in this. If you look at our study, the mobility tech spent maybe 14 or 15 minutes with each patient. And that was from the time they walked in the door to the time they walked out. So the actual mobility part of it may have only been 10 minutes. I think we took the time to break down a lot of those perceptions of, I'm not qualified to do this. This is going to take too much time. I'm not sure what level the patient is supposed to be mobilizing at, and broke it down. And when they saw that, the units started using it over and over again. And then it spread from the 9th and the 16th floor to the entire hospital. If you look, especially it's our medical service line, they implemented the Johns Hopkins highest level mobility for the entire service line. They implemented some type of visualization structure of that scale on every unit for every patient. And even for a while, it was discussed in the interdisciplinary huddles what level the patients were on the Johns Hopkins highest level of mobility. So while we didn't get the results that we were looking for the big goal, a lot of the things that we educated and implemented about have carried through even until now. And so we couldn't have been happier with that small win, that we just increased the understanding of the feasibility of mobilizing our patients and empowered our nursing colleagues that they could do it, that they could partner with us in the mobility. And overall, I believe that our fall risk is lower than it was before we started this pilot throughout the entire hospital.
I think it must feel so great for you all to know that from this one pilot study, you've had an impact that kind of lasted, even though you don't still have the mobility techs.
Yeah.
But I'm curious, Brian, I think Emelia was very in a very fortunate position that she had you as a director who was on board when doing something like this. And I don't think everybody is that fortunate to have the director. It's like, you know what, let's figure it out. Like, how can we do this? So I'm curious from your perspective, if we're talking maybe to clinicians that don't have that support, or maybe somebody who's a little more resistant to implementing big change like this, where did you get this mobility tech? Like, who was it? How did you train that person? Did it cost you all any extra money? Because I know cost can be a big thing. And then also, what would you suggest to somebody who's interested in maybe starting something like this, how to first approach it, maybe with their manager or director, and what would it look like to put this full scale long term? Like, who does it? Who pays for it? Because I think that's always a big thing too. Like, does nursing pay for it? Does therapy pay for it? What department do these mobility techs live? I know I just threw a bunch of stuff out there at you, and I know you probably have a lot of thoughts, but these are all things that have gone through my head in the past and thinking about this type of program.
Hey, great questions. And here's the good thing. So Amelia and I do share a brain on a whole lot of different things. And so if I cannot remember how to finish my sentence or finish a point, she'll jump in. So I'm going to call out on Amelia. So Amelia, jump in for things I missed or anything like that. So great questions. I think first of all, when you look at a project like this, where you're trying to move the needle, the best thing you can do is you need to see what are the economic implications, for better or for worse. So how much is this going to cost, but also what are we going to get from it? And I know sometimes clinicians don't want to, like, economics. I didn't go to, business school or anything like that. But if you know just the basics of economics and you can connect the dots to the right people who make the approvals, you will get the approval. The great thing is about this literature here is that it really is easy to put all together. So we use an unlicensed technician for this. Most of the PCTs would be it, or a therapy tech would probably be unlicensed as well. So the cost there is low. And then the other thing is we know how much readmissions cost on average. They can be, upwards of $25,000 a readmission. We know how much falls are, especially with injury. We know how much a delayed discharge day is. So we know these things. The literature has reported it. And then we also know, because of these papers, that we talked about back then with Groudon and Falvey and Hoyer and all the Hopkins people, we can connect the dots. Okay. So that's how you present your case, and making sure you pull it together. And of course, a lot of data to pull it back out. Once we talked with folks from that standpoint, and we realized that what is this hospital trying to accomplish? Like all hospitals, we want to have the best possible outcomes without complications. Hospital acquired deconditioning is one of those. We want to enable as many people as possible to be able to discharge home. Why should we waste money on, an additional nursing home stay if they walked in the hospital here? And of course, we want to reduce falls and suffering and things like that. And when we did this pilot, we did a little economics breakdown within the paper on it, and it came down to, I think, each mobility session with the tech was less than $15. Okay. When you compare that to what the cost of different supplies and pharmaceuticals are, radiology labs in the hospital, $15 is nothing. If you were able to get full efficiency scale, we feel we could have been more efficient with this if we had some more time. You can get it down to under $10 a visit.
Wow.
So the economics really pay off. So it's really kind of getting to the standpoint of how can we help the hospital and the nursing units meet what they're trying to accomplish with the resources we have. One final little piece is we were trying to find how can we get approval so that we can actually try this out. We knew what would be a very hard ask is to say, hey, can you give us one of your nursing techs for 6 months? Sorry, but we're just going to commandeer them. We couldn't do that. We used one of our therapy techs, physical and occupational therapy techs, who already knows this type of thing, how to use gait belts, how to use ambulation. And we said, here's the deal. So we met with the senior nursing leadership. So one important caveat when anyone is working on this type of stuff, you have to know your state practice act and rules.
Mhm.
Within Texas, like a lot of states, you have to have line site supervision, which is not part of this. So for this, we said, all right, for the 3 month where the mobility tech is operating, they are operating fully under nursing supervision, oversight, and all of that. We will keep that technician's salary in our department. There'll be a 3 month sacrifice. In this case, it was about $9,500 cost to our department, but we'll absorb it for the sake of quality improvement and data and investigation. But you guys have to oversee because the nursing, at least in Texas, but a lot of places also have much more lenient oversight rules as well. And this is what their techs do. So that was the final piece of the puzzle. Now, of course, you can't do this long term. It's a pilot study. So the final piece of it, and this is something that will kind of come and go. And as far as if it will be considered or depends on budgets at the time. But we had a lot of excitement about the data. And so the next step was how can we implement this long term? Okay. The one is, do you try to pull a nursing tech out of the staffing model? That's going to be hard. That's going to put more work on the nursing. Do you add a nursing tech or do you do it as standard work for the day? That's the way that our hospitals lean towards. However, with current day, there is a lot of staffing challenges for unlicensed care. So it's actually easier to hire nurses than it is for nursing techs. So that's one of the things. One of the things that really kind of also put it on pause also was that crazy little viral pandemic that happened in 2020. That was right when we were actually getting a lot of traction with this. And of course that caused a lot of havoc, but know the economics, know how things tie together, take the couple extra steps to speak the language to what the nurse managers are trying to accomplish.
Right.
Which is the same as therapy, which is the same as the CSO, which is the same as the CEO. We're all trying to do the same thing. We just got to connect the dots for people.
And if I could piggyback on that, Brian, everything you said was spot on, and everything that was going through my head, you answered. So I'm so glad that we do share brain cells. I think the other thing that could make it beneficial is we talk about the non-skilled or non-licensed staff.
Mhm.
When we broke down the economics and the time frame, we felt that a mobility tech could see 8 to 9 patients in the morning and 8 to 9 patients in the afternoon. That being said, we were able to split that mobility tech between the 2 floors. They were on one floor in the morning, one floor in the afternoon, theoretically. Sometimes they bounce between. If we look at a hospital floor that has 30 patients on it. What we average is 10 people don't need anything. They're perfectly fine. And you've got 10 that need a lot of help. They need therapy. They need to be seen by the therapy staff. But those 10 in the middle, those are the ones that would be beneficial to have a mobility tech or somebody designed to work with them. So instead of trying to say, well, we need one mobility tech for floor, no, you really need one per 2 units, right? And so when you start thinking about, and if you have a unit that has a smaller population, it gets even more economical. So you don't have to hire all of these people. What you need to do is do an assessment, a needs assessment of your unit, do an appropriate identification of where they are on admission and throughout the stay on their Johns Hopkins highest level of mobility or whatever assessment they do that discusses mobility. And if you don't have one, that's your first step. Implement one that's research-based and validated. But then now you can identify how many patients do you really have that would benefit from a mobility tech, and that would guide your need for how many people would you have to hire or on board to be your mobility tech. And I think that is another thing that people don't consider is sometimes you don't really realize you don't need that much, that it's not that hard to do, and you're not pulling resources from that many different places. Sometimes you can repurpose something that you're already doing. Once you identify that you really only have a third of the patients that really need this type of care.
You know, it's interesting just looking at the article. I see it again and again, this term of unnecessary bed rest, right? Just like you said, these patients, they were ambulatory. They were able to walk into the actual ER, and they were mobile. But then what happens is that everything kind of gets lost in the shuffle. And then there might be some staff that says like, no, then they say, you have to stay in the bed. Don't get up. We're going to wait until therapy sees them. And then now it's like, okay, so therapy is going to come see them, but and we'll assess them. We can give a recommendation. Now, if we utilize that Johns Hopkins highest mobility scale, we can actually communicate that this patient only requires so much when we give our handoff communication. The other thing I wanted to mention is that I want to give a shout out to Heidi Engel, who's out in California. And I've met her in different conferences. And one thing that she talks about, she's mostly in critical care, is the use of these mobility techs to kind of help out with some of these training sessions, right? Or therapy interventions. And so I'm wondering if there's a way to kind of, because I think she had mentioned this, of people that are interested in PT school, undergrads, or people that want to get their foot in the hospital and start working. And how cool is that if they get that experience working as a tech? Again, who hires them? I don't know if it's part of the PT department, if it's part of the nursing department, but they're actually working. If they're interested in PT, this is what, this is something that they could help out with, right? It's unlicensed, but they can help out with these patients that require some level of mobility. And then maybe down the line, those techs end up applying to PT school and loving acute care physical therapy. So I just wanted to shout out to Heidi because it's something that she had mentioned about how important and valuable the techs are, and hopefully down the line, those techs. There's a lot of techs that she had worked with that were very interested in PT school, and it was a great experience for them.
Well, Leonard, to tell you, that is where a lot of our students, they do that. A lot of them will tech in outpatient because it's more, there are more clinics and a little bit easier to get your foot in the door because you're working with a less acute population. But in my experience, I've worked with several techs who have gone on to apply to and be accepted to physical therapy programs. And my role is in admissions, as an assistant director of admissions, we do see that on the applications where people are techs in therapy or nursing techs, and they do apply to PT school. So it absolutely is there. And I think that's a wonderful recruiting and marketing piece to get more influx of therapists into the acute care setting and saying, hey, when we're doing those pre-PT kind of conversations when undergraduate and in high school, we're doing those recruiting fairs, steer them towards those PT departments and saying, hey, maybe consider not only doing your observation hours that you have to do to get in the PT school, but maybe really work in the field, get a hands-on view of what you would be doing, and make sure this is right for you. Make sure that this is where you want to be. Learn some things that'll give you at least some perspective on your journey through PT school, if that is your end result. And so I don't even think it matters if they do a certified nursing assistant or a PT tech. Either one really gives them infinite amounts of wisdom about how to interact with patients. And that's the thing. That's what we're trying to do. We're trying to interact with patients and we're trying to make their lives better. And one of the ways we do that is through mobility. And so I just think that that was a wonderful point. And yes, thank you, Dr. Engel, for all of your work.
Yep.
I think I'm probably a PT today in part because of when I remember when I was looking at PT school and then throughout PT school. Now, this is going to date myself, but I was a PT tech back when we literally did way more than we were probably allowed to do, right? Like now there's rules about what you can and can't do as a PT tech, but I did all the things like completely independent mobility sessions in hospitals, in ICUs, which I know now is probably like, we don't do that anymore. But you're right, Amelia. It gave me so much experience, and I think I'm probably in part an acute care PT today because
Yeah.
that experience I had of being able to do that mobility in the hospital and loving it and realizing the impact you can make. So I'm actually really glad because I feel like we kind of went away from PT techs for a while. They can do very, very, very minimum. So it's kind of nice to see us transitioning back to this like mobility tech role, which could give people some really valuable experience.
Mhm.
And I know we're at time for rapid responses, but I also wanted, is there anything else either of you wanted to bring up that we haven't brought up that you wanted to say to our audience before we move to our rapid response round?
I have one thing I'd like to add, and I think that this is, again, for those who are trying to get this started and you're not sure and you're doing your needs assessment. The biggest thing you could do to help your nursing colleagues, to help the therapy department, to help the hospital is that there has to be some type of standard assessment of how we look at patient mobility. If that is not there, that is a good starting point because you have to speak the same language.
Mhm.
Therapy and nursing and physicians all have to agree on what mobility looks like and where it is. So if I say the patient's mobility is a 4, that means the same thing to the nurse and that means the same thing to the physician. And we have the same goal of understanding whether that's their baseline or where there is room for improvement. And using that as a metric to determine if the patient is falling into hospital-associated deconditioning. Because remember when I spoke before, I said there are about 10 patients that don't need anything. We see them walking to the nurse's station, walking downstairs, going to get lunch. We're almost asking, why are you here? That type of thing. And those patients are fine. But if they do have a chronic condition or they do have a surgical procedure, and we notice that after that, where they were an 8, where they're lapping the hallway, we notice they've been here 5 days and now they're a 4, and we can't seem to move that needle. Now it triggers having a physical therapy referral. Now it triggers some other things. And so I think it's important to have that assessment where we're all speaking the same language, that nursing can adequately assess a patient's mobility on admission and at shift change each time they see the patient and use that as a metric to help us determine how our patients are doing while they're there. And I found that using the Johns Hopkins highest level of mobility was very easy, and it's used across hospital systems across the country. So when we start looking at comparing systems to systems, we're not doing apples to oranges. And so I just wanted to add that because I believe that that's a very important piece that's missed a lot. It's just having a common language of assessment.
Thank you, Amelia. That's great.
It's time, I think.
I'm ready. I'm excited.
I feel like we
sorry.
never
Game show.
transition. We never transition until I say it's time.
Before we transition to rapid responses, Acute Conversations has an important announcement. Ashley Poole will be leaving our team at the end of the year. We will certainly miss her insight, her passion, and her humor. It means that we are seeking a new co-host. If you have interest in joining our team, please email the show so that we can meet with you and determine if you would be a good fit. We only have 3 episodes left in 2024, so time is the essence. Contact us soon. And now, back to the show.
It's time. Like a Bruce Buffer kind of. It's time.
It's time.
For the rapid
Go.
response.
All right, I'm putting I'm going to do a 1.5 minute timer since there's 2 of you to give you a little more time to answer these questions.
Awesome.
Oh my goodness. Are we supposed to try to answer at the same time? Like, what are the rules to this game show?
Okay, for the two of you, we're going to ask you a question,
Yes.
and we can decide who's going to go first and who's
Yeah.
going to second if you'd like. And you're going to answer first thing that comes to your mind. So rapid, like, like rapid responses in the hospital.
Got it.
Just rapid responses on acute conversations.
Mm-hmm. And it's gotta be rapid, so it's the first thing that comes to your mind. Just spit it out.
Watch me say something like rabbit.
That's
That's fine. That would be really funny.
fine.
I'll let Amelia go first. She's a lot sharper than me.
Oh, goodness.
Okay, so
You are.
we asked the question. Amelia,
Okay.
you answer first. Brian, you answer second.
Okay.
All right.
I
Ready
got
to
my
go?
question ready.
All right, and go.
Amelia, what's your most favorite way to exercise?
High intensity interval training.
Fantastic. Brian.
Snowboarding, if I'm by a mountain,
Snowboarding.
which I'm not in Texas.
What's the last book you read?
Cardiopulmonary practice by Ella Hilligus.
Yes. Brian.
The Leonardo da Vinci biography by Walter Isaacson.
Oh, cool. Great author. Awesome. Amelia, name an influential PT on your career.
Rosalind Scott.
Very cool. Brian.
Amelia McCuen.
Aw,
that's
Our
not
guest
fair.
today.
I
Awesome.
love that. Name another podcast other than this one that you listen to.
Don't have one.
Okay.
Brian.
Gosh, what's the Malcolm Gladwell one? Revisionist History?
Oh, maybe.
Is that what it's called? Yeah.
Very cool. Amelia, your favorite scrub color.
Full black. So easy. Goes with everything.
Mm-hmm. Brian.
I'll say bright pink because we need more color in our world.
Cool.
I love it. Favorite dessert?
Ooh, strawberry shortcake.
For me, I'll say Maggiano's has a chocolate cake that's many layers and it's about 1,000 grams of fat and it's wonderful and delectable. I don't eat any desserts except for that one.
Amelia, describe your perfect pizza.
Ooh, has to be brick oven, fire roasted, thin crust, margarita style from Italy if we can, but if not, I'll take Grimaldi's.
Okay. All right. Brian.
Oh, let me see. We have a pizza place in Dallas called Louie's. It's a hole in the wall. The guys are from Chicago. But it's
Yeah.
thin crust and loaded up with sausage. I like jalapeno peppers and onion.
Getting hungry.
All right. Well, that's our time. So you have to answer our last question. You know you work in acute care when fill in the blank.
You don't breathe in through your nose.
That is so true. That is so true.
When the unexpected happens every single hour of the day, nothing that you thought was going to happen happened.
Mhm. And you still roll with it.
Unexpected.
And you roll with
Expect
it.
the
Thank you,
unexpected.
Roll with it.
Oh,
You know, Amelia, it defeats all of our cardiopulmonary backgrounds to not breathe in through our nose, right?
It does help you get through your day.
It really does.
It was funny. That was the first thing that popped in, but the second thing that popped in, you're in acute care when you know that OSHA or JCO is in the house.
Yeah.
And you walk the other way when you see them.
Oh, run! You are all of a
Yeah.
sudden super
You're like,
emotional, and
"Oh, I do
everything
not want to
she's
answer their
doing-
questions. Right? I don't have time for that.
Absolutely.
Lack of patience.
My answer
folks.
is
The responsible
Anyway.
thing to do is you got to talk to them. The regulators need to hear from us. Come
Coming
on.
from the director of rehab.
exactly. No, the question is, how long does it take you have to leave the equipment wet until it dries? The bottle says 3 minutes. I mean, you start having your recorded responses to what you're gonna.
Yes, you do. It's so true.
I love it.
Now I'll get these emails from the hospital. It's like, oh, Jaco's here today. And I'm like, I am so glad today's not my day to be in the hospital.
Absolutely.
Love and appreciate those people. But
Mhm.
yes.
Yes.
Amelia, where
Thank
can our audience find you? Do you have email, social media that they can read up more about you?
Sure. My email is emelia.mccuen@gmail.com. They can also email me at emccuen@bgsu.edu. Have a LinkedIn that is also under Emelia McCuen. Social media is, just for personal and family things. So I don't really use social media for professional roles, but I am always open and willing to collaborate with anybody that wants to talk about anything PT related. Acute care, geriatrics, cardiopulmonary is my jam. So feel free to reach out. And I look forward to collaborating and speaking with anybody who wants to continue to move our profession forward in any way.
Awesome. Thank you. And Brian, how can people contact you?
Best thing is just to email me. Same as Amelia, I'm ready to, set up calls. I like to learn from people, hear, what challenges they're working on, give it a shot. And what Amelia said is correct. She has not blocked my calls yet. She probably should have years ago because we've given each other so much work. This being one of the examples, but I'm kind of the same boat. I just like collaborating with people from different perspectives, different locations and all that. So emailing me is great. Dan is fine. I really don't check the other social medias that much at all.
Right, but we'll include all that information in the show notes.
And thank you both for all you're doing for our profession, and happy PT month to everyone. And let's go maybe try to prevent some falls this month.
Absolutely.
Yes, sounds great.
Thanks for having us.
Thank you.
We would like to thank Emelia and Brian for joining us on the podcast. Acute Conversations is the official podcast of APTA Acute Care. It is hosted by Alita Orgulis and Ashley Poole. Executive produced by Katie Brito and Edward Magnus. Music by Alexia Action from Pixabay. Sound effects also from Pixabay. For more information about APT Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us in 2 weeks for a conversation with Jenna, Rebecca, Ann, and Aaron as they return to the show to talk about pre- and postpartum care. Thank you for listening, and may your shoes and scrubs stay clean today.
Bam. First try. Killed it.